Welcome to the Provider's Report, where we delve into the world of value-based healthcare. Our mission is to empower healthcare providers with the knowledge and tools they need to deliver exceptional patient care. Each episode, we explore best practices, innovative strategies, and real-world examples of how to achieve the highest standards in patient communication and outcomes. Join us as we transform the future of healthcare, one conversation at a time.
In this episode, we revisit a standout conversation from the Better Doctor Project, a podcast I was privileged to host before the Provider's Report. The themes covered are highly relevant to our goal of advancing value-based healthcare, improving patient outcomes, and practitioner fulfillment. Enjoy. Hey everyone, welcome to another episode of Better Doctor Project. We are here with Dr. Josh Satterlee. Thank you so much for joining us.
Absolutely. Thank you so much for having me.
Of course. I'm really excited about today's episode. As you and I were just chatting, we're going to touch on 3 topics today. And I don't even know all that we're going to discuss, which makes me even more excited. I feel like I'm going to learn tons of great things today. So first and foremost, I'd love to know a little bit more about your background. Tell us and tell all of our listeners kind of what you do as far as your profession.
Yeah, well, I'm excited to be a chiropractor. Like I've been a chiropractor since, late 2006. So what are we at? Like it'll be 16 years in December.
Awesome.
I went through some ups and downs. Like there were some low points in there, but now I'm digging it. I think a lot of that is by the grace of God. I've found, I think, post-grad education that totally got my motor going and just totally connected with me. I would say the most impactful course I ever took was the SFMA, the Selective Functional Movement Assessment. I teach that now out on the road. I own a couple consulting companies. One is about business models, and it's called Clinic Gym Hybrid, because I think marrying a gym onto your clinic is just the perfect kind of business model to go from, hey, somebody's in pain, to how can you keep them as a long-term customer without selling them 19,000 adjustments.
Exactly.
And then we also just recently started what I hope we could talk about today, which is this education company around teaching providers more about evidence-based communication strategies.
Perfect. It aligns so well with Better Doctor Project. As a lot of our listeners know, there's just a huge part of our curriculum that is non-existent when it comes to things like patient communication. And then we all get out in the real world and we're like, oh, how do I talk to these people? I know how to tell them what their diagnosis is. I can tell them what I'm going to do for treatment. I can tell them when to come see me again. But if anything outside of a textbook happens in those 4 walls of the clinic, we're in trouble. So we talk about a lot of difficult conversations and situations on this podcast. And I'm really excited to hear about this evidence-based format.
Yeah, well, I think it's interesting because, like, you know, in the SFMA there's this slide we put up, and it says like the best doctors in the world have 3 major skill sets. Number 1, they are incredibly accurate at their diagnosis, right? They work hard to get an accurate diagnosis. Number 2, they have great treatment skills to match those diagnoses, or they know which ones to refer, right? And then third thing is they're great communicators, right? Yeah. And what's always funny to me is treatment, more than anything else, gets all the love, right? Like you look at all these great courses like MPI, DNS, ART, Graston, Factor. I'm trying to think of any others, but they're all the treatment thing. And you go, well, what about the diagnosis thing? And I think there's the SFMA and there's not much else, right? And it's like, well, we all agree that's the most important part, right? Like we got to diagnose. And maybe there's like some MRI interpretation and advanced imaging, courses and stuff. But then when it comes to communication, there are groups like Toastmasters or, professional speakers bureaus and stuff, but there's not a group out there teaching education specifically for healthcare providers. And it's like, well, not only will this make you more comfortable when you learn how to communicate, number 2, it's probably going to grow your practice, because if you offer the same exact treatment as I do, but you explain it a lot better or help that person connect the treatment you're doing to their goal, right? If it's a runner, helping them run more, and I do a really bad job and I just explain like, oh, well, this is a vertebrae and it does this and it rotates and, and they're just like, I don't connect with that. Your practice is going to grow way faster than mine. So it's great. And then the third thing is, so many times I hear providers complain about essentially what is termed non-compliance, which sounds like we live in some crazy, authoritarian state. But, they're just like, oh, I gave Rebecca the right, exercises. She just doesn't do them. And then it's in that weird catch-22. It's like, you think you're not as good of a doctor, or you feel like you're not getting the results. Your patient feels like they're not getting the results. But really it comes down to, did you communicate why those exercises were so important, right? And in doing so, that will help them get better. That'll help you get better results, which we all like doing. I mean, it's rewarding to see your patients do things and go out and achieve. And, it'll help grow your practice, because if you explain it and if you do a great job of that, they're so much more likely to send their friends and family. And you want to be the person they actually want to hear from, in your community. So it breaks my heart that it's not shared, or it's not trained about. And we're just going to try over the next 5 years to rapidly change that.
Yeah.
So simple, right?
We need a solution, and this is a great place to start. I'm loving it. And it doesn't exist anywhere else, and it needs to be widespread. And the cool thing I love about teaching on this is that whether you're a student, a first-year grad, 5-year grad, 30-year grad, you can still learn about this stuff. You can always be better. And a lot of the times it can be something so simple that we don't even realize we're not doing in practice. And that can be the golden ticket for new success.
Absolutely. Absolutely. And it's so, it's rewarding when we get it right, whether it's communication, treatment, or diagnosis. It's just so rewarding. And we want to help dive into that.
Yeah. And I mean, I'm sure you've had the same issues with your patients before, but so many of my patients will come in. I'll say, hey, how did your primary care visit go last week? Or how was your appointment with the neurologist? And they'll say, well, I didn't really know what he was talking about. Or I don't really know what he wants me to do, or I don't really know what my next step is. Like, they just have no idea, and they feel like they couldn't communicate with that provider. So it's clearly an issue.
Absolutely. And I'll tell you I think the thing that tipped me over the edge about starting this and actually diving into the research, unfortunately, was I had a friend who he ended up passing away from colon cancer, but he complained about low back pain first, right? 46-year-old guy, healthy, very active, very, just the atypical presentation for cancer. And his chiropractor missed it. His PT missed it. He went to a hip specialist, missed it. The MRI didn't catch where his cancer was, so that missed it. The orthopedic surgeon who he got a consult with missed it. And, it made me think, like, here's this smart guy. He's a very good communicator, speaks all the time. He's out on the road. He speaks at his church. How come that guy couldn't get across the message and didn't say the right words that would tell everybody this guy had red flags? And I think part of the issue is, so for you, Rebecca, you're obviously a great doctor. And when do we ask red flag questions? Just think about this situation. I just want to propose. When do you ask red flag questions?
So because of my former work at the VA, I feel like it was in my training to do it at every visit, which is not the norm. I'm going to be honest with you. And most of my patients, when I ask those questions, especially loss of bowel and bladder function, those kinds of things, they're looking at me like I'm crazy. Of course, I don't have any issues with that, but it's the one time, like your dear friend, that I'm going to be grateful I asked those things. But in our training, I just don't feel like it's as common to be so obsessive with those things. And it's great that it's the minority of the visits and of the cases, but we have to be vigilant about finding those.
Yeah. I think you bring up a great point. Asking at every visit, if everybody could change to that habit, I think you would actually catch red flags, because I will ask you this. Well, here, let me go back. I think the inherent problem is we're asking high trust questions like, do you have any loss of bowel or bladder control? Like, look me in the eyes and tell me, do you pee your pants when you get up out of a chair? A high trust question at the first visit, and even in the first 5 minutes of the first visit, which is like, can you think of any time in the relationship when it's a lower trust environment?
Yeah.
They don't know me. They don't know about my kids.
No.
They don't know anything. And it's like, hey, let me just start off by asking the most uncomfortable question that I could possibly come up with. Yeah. And you be honest with me. And so many doctors I know in every profession will tell me, like, they'll get what we call the lean in at about the 4-week mark. They'll go, hey, listen, I know you asked me before about bowel bladder control. I didn't want to tell you then. I actually
Yes.
have struggled with that.
Yes.
And if you think about what just happened, it completely
Uh-huh.
created a false negative. And false negatives in
Huge.
diagnosis is what kills people, right?
Hmm.
False positives are okay because we just do more testing. But false negatives is, I don't need to assess you for cancer when in fact I
Yeah.
do.
Yeah.
And the fact that you ask at every visit is a godsend. I mean, I wish everybody would do that. But let me ask you, how many, when you find red flags, what percentage of them come after, say, even the fourth visit? Like, so you're
Right.
well into care and now you realize there is a red flag.
Oh, absolutely. And you're right. Sometimes the patient's uncomfortable, but I've also heard of the provider just simply being uncomfortable to ask it.
Yeah.
And so, similarly to red flags, I find the same thing with asking questions about depression and anxiety. Can you imagine being a new patient in a waiting room and that's the very first thing the provider asks you? So, do you have depression?
Right.
Without even talking to them about anything else. I
Right.
mean, you hit the nail on the head. You have to establish a bond with your patient first. First and foremost, be a human being. Don't be a robot. Like, learn a little bit more about them before you touch on these questions. I love the way you just explained that, because these
Yeah.
questions are too important. They're too important to ask at the wrong times, and they're too important to forget about.
Yeah. So that's why we call this whole thing trust-driven care,
Okay.
because our goal is to help you communicate, but really what we're doing is build trust so that when you ask about depression, anxiety, loss of bowel or bladder control, when you ask about other factors that are affecting you, like if somebody's consuming a lot of alcohol, do they want to tell you that?
Right.
When you get it to that high trust environment, magic happens. We're getting accurate diagnostic data. The patient is feeling they're taken care of. And we struggle with this a long time. A lot of the research says empathy is the best. And I will agree, empathy is what we want to show our patients. But you and I'm sure both know very, very smart people who don't really come off with empathy. Maybe they
Definitely.
struggle with that. So our goal is, if we can just get you above this magical line of trust, the likelihood is you'll still get the same information that the empath would get, right? But on your worst day, if you're
Yeah.
totally not empathetic or you're dealing with something yourself, are we still above that line to get accurate data? And if we can get everybody above that line, it solves a lot of problems. Now, if on top of that, you can be super empathetic, it's, your people are going to be doing
Dreamland.
backflips. Yeah, exactly.
Yes.
But
Yeah.
don't think it's just trying to connect emotionally. The reason for that is we have to get above that line of trust to get accurate diagnostic data, especially just for red flags. If only for that, we have to, because it's a totally subjective response, right?
Oh, yeah.
There's no way to
Absolutely.
objectify that. So,
Well, I think I like it the most too, because by you creating this, you are accepting the fact that all providers are different, and we need to acknowledge that. Some are going to have that natural ability to make that patient their best friend,
yeah,
if you will, and that patient's
yeah,
going to be, for example, I have been blessed with that. I'm a major empath. My patients feel like they can tell me everything, sometimes too many things, and that's great. But I was just doing another podcast interview, and we were talking about how many other personality types are introverted people. Introverted people
right,
belong in healthcare, but this
right,
is one example of many where this strategy, this evidence-based mindset toward patient communication, can take them to a whole nother level with their
right.
communication and get them the results that they need to get. I love it.
Yeah, it's a, it's funny when we set when these filters create a certain situation. Like, if you think about who makes it through undergraduate with a high enough grade point average to apply for grad school and PT, Chiro, med school, whatever. Well, you're probably a little bit more of an introvert because you're willing to buckle down and study all the time, right? And then who makes it through that program? And then if there's a residency on top of that, who makes it to that? And it's like we're filtering out all the extroverts, all the socializers, because we're predisposing to people who are willing to stay home and not talk to people and stare at books. And
Yep.
and so who do we end up with in healthcare? I'll tell you, my dad unfortunately had brain cancer, and his neurosurgeon was the warmest, most like the guy would just walk into the room, he'd pull up a chair, sit down, take a breath, and he would look at my dad and say, So how are you doing today?
Wow.
Because in the world of brain cancer, every day is a battle, right? Like, and you don't know what it's going to be like. But he would just ask this totally open-ended question. And then that was his neurosurgeon. I asked, like, how did you, like, you're different. He goes, oh yeah, I only made it through because I was in the Army and, you know, they pushed me through and blah, 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 blah. So normally a guy like me would never make it this far. He was very open about it. But then my dad's oncologist, so the person managing the, you know, cancer non-surgically, was, if you called up Central Casting and said, I need a nerdy, he was an Indian guy, but I need a nerdy, by the book, super structured doctor, this guy would show up, like very poker faced, very like, how, you know, Mr. Satterlee, can you give me the, you know, how are you today? Okay, great. And my dad would never even answer the question. He would just say, okay, great. Let's check your vitals. And I want to review your medications and, you know, blah, blah. And it was just like, it was so polarizing to see those two operate on the same patient in the same hospital. And the thing is, I would label both of them as incredible. They were very good physicians, but just having that ability to communicate and show a little bit of empathy at absolutely the worst time in my dad's life was like, you see what a stretch those two things can be.
Oh, absolutely. So tell us a little bit more about what you're doing with this. What's the plan?
Yeah. We're just trying to change the world, Rebecca. That's it. I mean, super easy, super simple. Yeah. So if you could just recruit, 500,000, 3 million people, whatever you got, and we'll just change the world. No, so I love it. So we dove into this, and we wanted to take an evidence-based approach, or at least an evidence-informed approach, and really look at what is the problem we're seeing. And when you dive into anything about communication, you realize that what the patients seem to want or ask for or respond in surveys and whatnot, and what doctors think the problem is, are disconnected. It reminds me of that movie Moneyball. Have you ever seen that with Brad Pitt? And he's talking to his scouts like, so what's the problem? And they're like, we know what the problem is. And Brad Pitt's like, so, okay, great. So what's the problem? I think that we're like that with healthcare communication. I think most physicians and I'll just say providers, because it could be even mental health or anybody, even occupational therapists, right? It doesn't matter. Think that we have to communicate the disease. We have to communicate the biology. We have to communicate the anatomy. And although it's important to know those things, what the research says is you have to treat this person as a whole entity before you address the disease. And so I always try and come up with analogies to explain this, but I'm sure everybody has worked with a person who is a runner and identifies as a runner. And running to them is so much more than caloric expenditure, right? It's maybe their mental health thing. It's their feeling of achievement. It's like the way that they stay sane, whatever it is. I'm sure you've dealt with this person where they have like the magical, they have to, I'll just pick some random number, 6 miles. If they don't get past 6 miles, they haven't quote unquote run. They could run 5.8 miles. They haven't gone on a run. And they need to get past that point. Well, when that person comes into, say, a chiropractor's office and is like, oh yeah, I have this pain in my back that keeps me from running. It's so important to help understand what their goal is, because their goal may not be, in fact, to run without pain. They might say, I'm willing to deal with pain, but right now I'm at a 6 and I need to be under a 4, but I'm still going to run. But what they're not willing to do most of the time is go to no running in exchange for no pain.
Absolutely.
And that's their identity. And so if we strip that from them, they're not going to be compliant. They're just going to doctor shop. And I mean, I'm kind of stereotyping here. They're going to doctor shop to find a person that's not going to tell them not to run, because they need to check that box. And it was super clear to me one time. I had a patient that was like that. And this woman was just incredible, ran every day. And I mean, every day, whether she's on vacation or at home. And she was super warm and welcoming and said, hey, if you ever want to run, let me know. And she would, like, people would come into Vegas and they'd say, where can you run? And she would meet them or pick them up from the strip, take them out, because I live in Las Vegas, take them out to some trail and go, hey, we can run here, stuff. So she's and one day I asked her, I said, hey, listen, I'm concerned about your foot. Like, she was coming in for heel pain. And I said, I'm very concerned about your foot. And I hate to say this because I know you run a lot, but we may need to take some time off running. And like, she got a total look I'd never seen on her face before. A tear rolled out of her eye, and she leaned over, she put her hand on my leg, and we were we'd had a relationship for probably 3 years. So she knew she could trust me.
Mm-hmm.
She said, listen, I've never told you, but I run because my son died of leukemia. And on his last day, he said, I wish I could go outside and run. And so she's like, I'm carrying that forward and I get people to run. That's why I do it.
Wow.
So we can do anything. I'll do whatever you want me to do, but I will not stop running.
Wow.
And it's like,
huh.
I'm just going to sneak over here and cry in my palm for a while, and then I'll be right back to treat you, you know?
Oh.
But the point is, people that, you know, we in our process, we call it the patch, the PATCH, and P is patient's goals. And it's imperative for us to understand our patient's goals and understand what are they trying to do rather than understand just the disease. We have to understand the disease, but what is it that we're really going after, and what is that patient identifying? What are their goals is so important, because it just puts that lens on there. And I think anybody listening, like if you had that woman, her name was Kim, I can remember, I can see her face, I can see everything about her. If you have that person in your office, you realize quickly it's not about the anatomy of the sesamoid bones and how the windlass mechanism works in your foot. It's not about how thick the fat pad is. All those things have now had a value of 0.
Yes.
What it's about is, how do we preserve Kim as a runner? And what do we need to do? And if you look in the research, so many times patients will say they were not talking to me. They were not addressing my goals. They weren't addressing my issues. And they're begging for us to do it. And that's just one step that we found in the research. But it's this huge disconnect once again, which is funny, because everybody I know that's a chiro, PT, a strength coach, everybody, we love people. We love it.
Yeah.
So why does it fall off? I don't know, you know?
Our training is so black and white sometimes. And the second you start working with a human being, you have to kind of throw all that out the window. I mean, even when it comes to diagnosis of a musculoskeletal condition, it's not black and white all of the time. You know, we have algorithms that we follow. We do trials of treatment, and we do more testing depending on what we need to do to solidify that diagnosis. And if that can be non-black and white, imagine dealing with a human being. I mean, have you even seen that sometimes your patients don't even know what their goal is? And then just through talking to them in that first visit, you can find something like a functional goal. And the second you bring that up, they light up and they realize, you're right, I haven't done yoga in 2 years because of my hip pain. And then instantly when I say, what a great goal, how about we get you starting to do some yoga after we do this therapy for a couple of weeks? And then their whole world has changed. In that moment, they realize you're not there just to treat something that's in a textbook, but you actually care about them, their quality of life, their well-being. I mean, I think it's almost crazier sometimes when they don't know their own motivators.
Right. And I think at that moment, like going to this, you know, barometer of trust, like what happens when you get on that page with them, when you bring that out in them, what just happened to the trust? And again,
Magic.
right after that, you talking about like, hey, what if we got you back to yoga for a couple of days? If you were to ask a red flag question, right then, the likelihood of it being more accurate is, it has to be 25% higher, 50% higher.
Has to be.
Know?
Now I'm going to be thinking about that study in my head. Like, you're so right, though. I mean, have they done studies on that?
Yeah, on what?
On like when to ask those questions? Yeah.
Yeah. The worst time is when we're trained to ask, which is the first. Yeah.
Yeah.
What we should do, if everybody's listening, as a general rule, I mean, take the, you know, I'm consolidating a lot of research here, but you should ask the lowest trust questions first. So that would be like, where does it hurt? What's the pain like? Right. And we get up, and it's tough. You cannot offer any judgment about that. That's a trained skill, right? So it's going to climb. And at the end, a great question is there anything else you'd like to share with me, or anything I haven't asked you that I should have asked you? So using those words, I didn't ask that I should have asked, right? And they might say, well, Dr. Day, you never asked about my shoulder. Now, you know, don't freak out and go, well, you never told me about your shoulder, Sally, you know, which sometimes we want our pride to do that. But if you say, and what is it, if you can open it up, and what is it about your shoulder I should have asked? They will start revealing information. When they're in the revealing mode is a great time to ask a red flag question or your series of red flag questions. So along with your shoulder, let me ask you this. Or another way to phrase this that might help people is take the pressure off of them of giving you an answer and put it on someone else. So I'll tell you 2 tricks about that. If you come in and you say, I'm dealing with back pain, I go, all right, Rebecca, how bad is your back pain? And you say, oh, you know what? It's not that bad. So it's somebody that's kind of pushing it off.
Mm-hmm.
Take the pressure off them and put it on somebody else. So Rebecca, let me ask you this. If I asked your husband how often you're in back pain, what would he say? Oh, he'd say it hurts every day. I can't even unload the dishwasher anymore.
Wow.
Okay, what would you rate it as? Oh, it's just a 2. It's a 2 out of 10. What would your mom tell me it was? Oh, she'd say it's an 8 out of 10.
Wow.
So you're taking it off them and putting it on someone else. Or
Yeah.
for red flags, I can say, Rebecca, I know your back hurts. And some people come in and tell me that when their back hurts, they also have a loss of bowel or bladder control. Has that ever occurred to you? Or has that ever happened to you? Have you ever felt that? Have you ever noticed that? And they go, that's interesting. Or it's common for people with this diagnosis to also have this. Now, I'm not saying you do. I just want to get the full picture. So do you ever suffer from a loss of bowel or bladder control?
That is the single-handed best way I've ever heard of that being said.
Well, I guess we're done here. It's pleasant.
But they immediately realize if they are having any of those symptoms that they're not the only ones and that this is possible with back pain. I've had some patients, if I do ask those questions, they're like, I'll explain to them, this is what you can, look out for if I have a really severe case, for example, bilateral lumbar radiculopathy or something, scary, but I've ruled out all red flags. I will let them know. If you notice any numbness and tingling on both sides of your groin, as well as loss of bowel and bladder control, please immediately go to the ED or urgent care. We have that conversation. And they're always like, this can happen with back pain? A lot of people don't know that. And the way you just described it, they instantly realize, oh, this is something she's seen before. I can tell them that I haven't been able to have control for the last 12 hours or what have you. I love that. That's such a great way to do it.
Yeah. It's interesting because in any other situation, if we take it out of medicine, like how would you talk to a young child if you were concerned about somebody abusing them?
Oh,
you
absolutely.
Wouldn't sit them down and be like, hey, tell me about the abuse. It's like you would spend time to warm up.
Course.
You would build trust. You would draw with them. You might share, play with them. You would do something to get on the same page. And then you would slowly peel away these questions. And in medicine, for some reason, we're trained and we go, all right, forget that. I'm not dealing with a human being. I'm dealing with a collection of cells here. So Rebecca, tell me, with your back pain, do you ever have a loss of bowel or bladder control?
Yeah.
And even the way we phrase it, like that's a horrible way to phrase it. Like, or incontinence or constipation. It's a horrible way to phrase it, right? It's like we need to talk to a real estate agent. Like, how they describe this place is a handyman special. That means it's like falling down.
Yeah.
How would you describe the loss of, control of your bowel or bladder? How would you describe that to a patient? And even coming up with better words for that, like, hey, whenever you stand up, do you ever leak urine? It's probably a way better way to ask about incontinence,
Yeah. I love it. So tell me more about PATCH. I know there's an acronym for this.
Yeah.
You touched on the first part. So
yeah. So as we went through and, it's one of those things, if you dive into PubMed, I think we're up to we've probably looked at 200 articles and really grabbed about 55 of them that we thought were impactful and kind of applicable to especially MSK, musculoskeletal therapists like ourselves. And we kind of grouped the information into 5 big ways. And the reason we call it PATCH is in honor of Patch Adams, who was like the greatest communicator in medicine, right? So the first one is make sure at every step, you want to make sure you identify and you're clear about the patient goals. That's the P, patient goals. The A is autonomy. Get into an agreement or discussion or identify what parts the patient will do, what you're going to do, what your front desk is going to do, when you need to refer or imaging. But what is the patient autonomy? Like you're saying, if you feel this, go to the ED. That's autonomy. And we're going to agree that the person in front of us can handle some aspects of their care, but there's some aspects where we're the person to handle it, right? So autonomy is number 2. T is tailoring communication style. So there's two things about communication that we're going to do, but the first is tailor it. So if I'm trying to explain to you and you have a disc herniation and I'm trying to explain that to you, verbally may not work for you. I may need to hand you a model, like a joint model, and all of a sudden the lights will go on. And you'll understand why I'm talking about protective mechanisms or like changing your ergonomics so that you don't keep flaring it up. When you see, those models that maybe show the bulge shooting out and stuff. So we're going to tailor that. The other point I want to make here is if there's like 5 things you treat in your clinic more than anything, it wouldn't be bad to put together a really quick PowerPoint presentation or Google Slides, pertinent anatomy, demonstrations, a mini video. For kind of the 5, usually in an office, 5 to 8 things will get you about 80% of all your diagnoses, right? So that's the T. The C is communication basics. So just the basics of communication. Do you shake their hand? What's your body language like? Are you making eye contact at the right time and for the right moments? Are you, have you ever seen those studies where like if you sit next to the patient or 90 degrees to the patient or facing the patient or have a desk between you, what works? So they call that setting the healthscape. So again, if we're going for this high trust questions, maybe you need a different room than the cold exam room with the stainless steel table or something like that. Maybe you want a lounge kind of feel. So set that healthscape and just focus on the communication basics. And then finally, the H is humility. We have to practice humility at every point, because that really opens the doors to get more information that's more accurate, and it reduces the likelihood that you will be sued for malpractice. In fact, it reduces the likelihood you'll be sued for malpractice more than anything else, including doing the right care.
Amazing.
It's a crazy stat, but even if you did the right thing, it's still very likely you could get sued if you are not humble, which is a crazy thought.
Yeah. Can you give us an example of that? Like a good situation that we need to pick humility over what we may want to do in that moment?
Yeah. So I don't want to stereotype, but luckily the research did it for me. And it turns out that hospital-based surgeons are the highest group of lawsuits in any hospital, right? And one of the reasons is they're the lead dogs, right? They're usually at the top of that medical pyramid. And sometimes they are not humble. They're, in fact, maybe a little bit pompous. Well, it turns out that malpractice lawsuits, we say malpractice, but that's probably the wrong term. And so you can actually get sued for doing the right procedure on the right patient for the right reasons, but not having the right approach in it. So, for example, this is crazy, right?
Yeah.
But the good news is when there's millions of dollars of lawsuits at a hospital, they start studying it pretty actively about why are we losing all this money? Right?
Yeah.
So it's DDDR, I think it is. If you are demeaning to a patient, if you devalue their information. So if I ask you about your back pain, just tell me make up some facts. I go, Rebecca, where's the pain and what does it feel like?
Oh, sometimes it's on my right side, but sometimes it's on my left.
Well, which one?
I don't know. Sometimes both.
This isn't, you don't need surgery, and I just devalue you. Likelihood of lawsuit just jumped by 3 times. By 3 times. I haven't even done surgery on you. I'm already up there.
Wow.
Devalued, demeaning, forgive me, I forget the last D. And then if they feel like, if my behavior was that I don't care, meaning I didn't sit down in the patient exam room, I rushed the visit. A common one is they don't even go into the room. They stand at the doorway and ask questions, which I've seen with both my parents now that it got brought up, and I'm like, yeah, I don't want to do that. But I'll tell you the one that connected with me. Last year, excuse me, I was walking around running errands and this is like out of a textbook. I had this pain and felt like my bladder was full, like I really needed to pee, right? Went to the bathroom, peed, nothing changed. I'm walking around, I'm running around running errands, went to the bank, went to the supermarket, and I'm coming out of the supermarket and I step off the curb in front of the supermarket and it feels like somebody stuck not a sharp arrow, but the shaft of an arrow through my body, like through my bladder all the way to my spine. And I was like, oh my God, that's rebound tenderness. Like I just felt it, right? And it was unbelievably painful. So I went to the urgent care, which actually was in the same parking lot, and amazing physician there, did a great exam, great history, very warm individual. He's like, all right, let me palpate your abdomen. So he's going around searching, and he hits this point about the size of a quarter. And I do that move where I reach down at lightning speed and grab his wrist, like, the international sign for don't ever touch me there again, like that. I didn't even need to use words at the time. It was amazing. And he looks at me and he says, okay, well, you need to go to the ER. And I was like, why do I need to go to the ER? And I loved his response. He used my name and he said, Josh, because most healthy 42-year-old males don't grab my hand like that when I palpate them very gently. And I was like, He didn't say you have all the signs for appendicitis.
Yeah.
Or, that's right over blah, blah. He just said, because that is so, and it really like caught me off guard. I'm like, he's right. So I went to the ER and found out that I had a bout of diverticulitis. So it was on the wrong side of appendicitis, but it's still inflammation low in the abdomen. So I get a CT with contrast. And at this point, I've been going through medical evaluation for about an hour. And even me, with all my knowledge and all my, I'm starting to get the nervous sweats. I'm like, this is not my finest moment. And so the ER physician comes in to deliver the diagnosis, and she is, I'm trying to describe her. She's probably somewhere between 35 and 40. A tall woman. I would say that she's, she's in shape. She looks like a runner. She's fairly attractive. So there's no language barrier. There's no barriers whatsoever. I don't feel threatened by her. I don't feel, you know what I mean? Like all the things you can think of just like body language and whatnot. But she is as cold as ice. I call her the ice princess. She comes in and says, okay, I looked at your CT. You have diverticulitis. That's it. That's all she said. And I said, okay, what does that mean? Well, there's an outpouching of your colons causing the pain.
Oh, no.
Okay. She's like, well, I'm going to admit you to the hospital overnight because we need to observe you and see if you need any surgery. I was like, and I stopped and I said, okay, but doctor, I got to tell you, like, I don't feel any warmth here and I'm really nervous. I'm scared and I don't feel like she's like, well, I've done my job. My job is to diagnose you.
She said that?
Yeah, I've done my job. My job is to diagnose you. And I was like, wow. So they had, because I was getting admitted, they had to transport me because it's a freestanding ER. They transport me to the hospital, right?
Yeah.
That entire ambulance ride, I wanted to sue her. And it struck me like, why do I want to sue her? She got me an accurate diagnosis.
Right.
She did the right diagnostic tests.
Right.
She gave me the information. She explained it's an outpouching of your colon and it flares up. And if it leaks into your abdomen, we have big problems. That's why I'm going to admit you. Like, on a checklist, she had hit every marker. Wow. But from a human to human perspective, I was angry. I wanted her to pay the price for something, and I couldn't figure out what it was.
Wow.
Now, obviously, it's being overlaid by this fear and my fear, my nervousness. But it really, between that and my friend passing away, has just been twirling in my brain. Like, me as a provider, I've struggled with patients. There's been days I haven't been super empathetic. Why do I want to sue this woman so bad for malpractice? And she didn't do anything wrong. Like, literally did everything right, and in fact probably helped me. But it's like, wow, even I can't separate myself from that kind of human need for warmth, explanation. Yeah. And when she was not just cold, because what other patients are going to call her out on that? Like, hey,
right.
I don't feel warm.
Yeah.
And she responds with, I've done my job. Like, oh my God, we have such a problem with communication in healthcare. It is unbelievable.
It's really bad. And patients are so fed up with it. And I honestly, I think even more so now in the post-COVID era, but ever since COVID, I feel like patients are becoming a little bit more outspoken about that kind of stuff. And they're looking for more answers from us. And they want to be able to have conversations with us and don't want to feel that there's this huge barrier between healthcare providers and patients, because there shouldn't be. I do support the way healthcare has changed into the group practice mindset. And I do
Mm-hmm.
support, technology reform within healthcare and all of those things. But I think we're missing a lot of that mom and pop feel from 60 years ago when people did have relationships with their primary care physicians, because
Sure.
they did. I mean, the doctor knew who your mom was, they knew who your dad was, they knew how many kids you had, they knew all of these things about you. And the second we lost that, we lost a lot of that trust component that you're talking about. And so we have to
Yeah.
find a way to gain that back, because with how big the world has gotten and with how big healthcare had gotten, the reality is we can't know all of those things the way we once could. So this is a great alternative to still be able to develop that communication, that trust, that relationship, because it is possible. And clearly there's an evidence-based way to do it.
Yeah. And going back to what you said about what patients want, there's a great study where they had a third-party observer go into all these patient visits in a hospital-based setting, right?
Mm-hmm.
And afterwards, the third-party observer would score how effective was the doctor at communication with the patient. So effectiveness, we're not even asking for warmth here, right?
Mm-hmm.
But effectiveness. Then afterwards, they would ask the patient, hey, how effective was the doctor? And then, just to make the study complete, they'd ask the doctor, how effective were you at communicating with that patient? Here's the scary thing. The patient and the third-party observer, this is neutral, probably a grad student, working on their PhD, would almost always rank the doctor in this low 60s, 62% effective, 64% effective, but they agreed. They're both saying like this is a D. Sometimes you would see that drift up to like 70%. 70% effective. The scary part was, guess what the doctors rated themselves? 85 to 90% effective.
Oh, yikes.
So it's not just that they're bad, it's that they're bad and assume that they're good, right?
Right.
This is the worst combination, because if they're bad and think they're bad, at least they'll work to change it, right? Now, the craziest thing was the lowest scores were often in hospitals that had already implemented communication training with their doctors.
Oh, no.
So these are trained people. Now, the question we don't know the answer to is, did they know the scores were low and the doctors, they put the education training or the communication training in there because of reports of low, or is it 62%? Would it have been 40% before the communication training? We don't know that, but we just know that oftentimes the communication training had already occurred and you're seeing low scores by the patient and the third-party communicator. And by the way, patients always rank the doctor lower when asked that. And I think in the world of chiropractic or physical therapy, when you have a lot of cash pay patients, they vote with their dollars. They're not going to tell you you're 62% effective. They're just going to go pay someone else to be that effective.
It's so true. And think of it this way too. Imagine a bunch of fresh graduates in practice, regardless of what specialty you are. You had just gotten done with whatever training you got in terms of communication, or let's say you excelled through medical school, chiropractic school, PT school, whatever it was. If someone sat you down and asked you to rate your communication skills, if you were a straight A student, or if you did well in your training, or let's say you have a successful practice, I can kind of see why you might rate it as 80, 90%, because you might think that you dominated school, so you must be good at it. But in reality, we just don't know any better because we didn't have the appropriate training that we should have in our training, which is just so painful.
Yeah.
Yeah.
But I mean, schools aren't, their job is not to make us amazing clinicians. Their job is to get us to pass the state board exam,
It's so true. It's so true.
Yeah.
Well, I love
That's why we need great podcasts like yours that are pushing it forward for everybody. I mean, that's the way it will change.
Yeah. Yep. And you guys obviously have the same mindset. We have to get all this information out there and we have to help providers wherever they're at. You also mentioned that you have an evidence-based apology set up. Can you tell me a little bit more about that?
Yeah. I always laugh when there's certain things in the evidence where it's a question that's burned in my mind, or, and it would not just affect my relationship with patients or my abilities in the clinic, but really would affect every part of my life. And so we're downloading all this, looking at all this evidence, and we came across, this is in that malpractice kind of area. And it's someone was going along the way and said, how come when our surgeons screw up and they apologize, are we still getting sued? So if you want to know how to apologize to a patient, there's actually an evidence-based 4-part apology framework. And here's one thing that is funny to me. In the research, it clearly states, apologize. If you think you screwed up or the patient said you screwed up, just apologize.
Mm-hmm.
Now, your malpractice carrier strangely will tell you the opposite. Do never admit guilt.
Mm-hmm.
But it looks like, and there is a line in one of the studies, I just wanted them to apologize. That was a common response from patients. I just wanted to acknowledge they were wrong. I wanted them to acknowledge they were wrong. So the patients are asking for it. So if I was going off the evidence, I would say, if you get into a sticky situation, apologize.
Huh.
We can fix everything later.
Right.
But if you're going to say like, hey, I'm not going to apologize, cool. The problem's not going to go away.
Mm-hmm.
You know, it's interesting because, you know, in general right now with, you know, different groups, apologizing sometimes is seen as a sign of weakness. But I would say the evidence in medicine says apologize. So the 4 parts of it. So they said, if somebody delivers what they called a non-apology, it was missing one of these 4. Okay. So you can think about it. If you hit these 4, it's interpreted as an apology. So number 1 is acknowledgement. Just acknowledge that you were wrong and this person is angry. Number 2 is explanation. So you can talk about what happened. Do not explain why you are correct. Just explain what happened. Mm-hmm. Number 3 is clearly offer regret or remorse. And then 4th is some sort of reparation. So let me say them again. It's acknowledgement, explanation, regret, and reparation. So AERR. Okay. Mm-hmm. So I'll go through it with you. Let's say that you had back pain and you got worse after my visit, and you think I wasn't paying attention to you, or I don't know what it is. So say, Rebecca, acknowledgement. Rebecca, I understand that you're upset, and I want to apologize. I understand that, and then I can move into explanation. I understand that when you left, your pain actually got worse, and you called the office twice and nobody answered. I want you to know why that is. It was my responsibility to take the cell phone home with me, and I had forgotten. So as the phone rang, there was nobody here to answer it. It's not typically our policy, but you got caught in that, and I can see that was detrimental to how you feel. And then I'm going to move towards regret and remorse. And it's easy if you just state the word sorry in here, but I'm very sorry that you suffered for 2 days and no one was calling you back. And I apologize for the fact that you basically were left there and nobody contacted you. And then I have to offer a reparation. In the future, here's what we're going to do in the future. Now, it doesn't have to be reparation about them, by the way. You can just say, as we move forward, you helped us realize that cell phone is a key issue, and we dropped the ball on that. So as we move forward, that will always go home with so-and-so, or we're hiring a answering service so that they can reach out to me or the office manager or the nurse to make sure people like you get taken care of in the future.
Wow.
Yeah.
Yeah, simple enough too.
Yeah, so it's just 4 parts. But think about all those times you've heard like a politician, mm-hmm. They never talk about the reparation, what they're going to do different, right? They say thoughts and prayers, thoughts and prayers, thoughts and prayers, but they never say, I'm sorry. They never say the reparation. They don't acknowledge it usually, you know, and they do a horrible job of explaining. If you miss one of those parts, people aren't going to think you're apologizing. So, I mean, think about times with your husband. I'm sure that he's stumbled over apologies. If you go back and think like, what was it that he missed? Is he not a acknowledger? Does he not do a good job explaining? Is it that he's not doesn't show regret or remorse? Or is it that he doesn't offer any reparations? And you bring that up and you just show him that. If he fills that in, it's crazy. You will feel better even after you show him how to apologize to you. The next time it happens, you'll be like, wow, I really love this guy. Like, this is why, and it's just crazy that we can do that. But we're human beings. We are amazing creatures, and our psychology works in mysterious ways.
And I feel like when you hit all 4 of those parts, no one can be upset with you. I mean, like, what is there
The only downside is offer a reparation you can actually follow through with.
Yes.
Because if you offer a reparation and like, oh, Rebecca, you got to trust me. This will never happen again. Mm-hmm. So like, for those listeners, I totally dropped the ball and I missed our last interview, right? Mm-hmm. If I say it'll never happen again and I'm going to X, Y, Z, And so I talk about this, here's what I'm gonna do. And then I miss it again. You're now more mad than had I not offered some sort of reparation, because now I've unfulfilled twice on that, right?
Sure. Attainable.
So,
it's like setting goals. I like it.
Yeah. And so the reparation doesn't have to be huge. And it doesn't say, the research doesn't say, so Rebecca, we're not going to charge you for today's visit. It never says that, right? So don't think that that's the financial motivation is the only way to do it. Just talk about how you're going to improve the system, and then actually improve the system.
I love it. This episode has been gold. I think you're doing such a wonderful thing, and all of this information is so applicable right away in practice. How can our listeners find out more about you? Where can they go?
We're so new at this. Like, we got through the phase of getting the research and whatnot, but we are setting up a website.
Awesome.
At trustdrivencare.com. It's so new. The website's not done, but maybe if people want to listen to this and then listen to it again in 6 months,
Absolutely.
It'll be up and ready.
Well, we feel blessed to have you on our show so early as well. I can already tell you guys are going to do some amazing things.
Yeah, you'll be like those people that go like, oh man, I knew about the Foo Fighters in 96, long before they went international.
Definitely. Yeah. Well,
I'll send you a vintage Trust Driven Care t-shirt so you can be like, this, you can't even get these anymore.
What about an album cover, music release?
For sure.
Absolutely.
Yeah.
Well,
absolutely.
Josh, thank you so much for joining us. This has been a pleasure.
Absolutely. Thank you, Rebecca. And I really dig what you're trying to do, because, there's so many ways to get better. And I've listened to so many of the episodes, and everybody brings up a great point about how we can be better to our patients. And we got to be. I mean, if you look at the $3 billion was spent last year just on low back pain, and it's 50% or more of all the complaints. And just in musculoskeletal care, low back pain has been researched more than anything. How come we're not making progress there?
Right.
And
we're missing a key piece.
Yeah. It's going to be motivated people who are listening to podcasts like yours and implementing what they hear, or getting that new education, that are going to be like, I at least in my practice, that number is going to change. I can't talk for everybody, but in my practice, it's going to change.
Absolutely. I agree wholeheartedly. Thank you so much.
Absolutely. Thank you.
Thank you for tuning in to the Providers Report. We hope you found today's episode valuable and inspiring. To stay updated with our latest episodes, subscribe to our podcast wherever you like to listen. For more resources and continuing education opportunities, visit our website. Together, we can make a difference in the lives of our patients and truly set a standard for value-based healthcare.